Evaluating the difference between delirium, depression, and dementia. Delirium, dementia, and depression are the most common and yet most challenging diagnoses for older adults. Delirium itself is difficult to diagnose, dementia is challenging to treat, and depression increases with ages normally. These syndromes overlap and can occur simultaneously. Delirium is a cognitive disorder characterized by the acute onset of an altered level of consciousness, inattention, disorganized thinking, memory impairment, disorientation, and perceptual disturbances. This is very common in the acute care setting, in that about 40% of older adults who are hospitalized experience delirium. It also occurs in residents of long-term care facilities. Delirium has 3 common types. The hyperactive form, which includes behaviors of agitation, restlessness, irritability, combative outbursts, and hallucinations. The hypoactive form, which includes behaviors of somnolence, decreased vocalizations and motor activity, and cognitive detachment. This is typically less disruptive than the hyperactive forms. Mixed delirium includes characteristics of both. It should be noted that delirium is associated with increased morbidity and mortality. One great way to assess for delirium is the Confusion Assessment Method, CAM. Treating delirium usually looks like allowing it to resolve over time in patients and providing supportive care, environmental changes, and behavioral support. Sensory deprivation is a major risk factor for delirium, and so making sure that the patient has their glasses, hearing aids, etc. is an important supportive care. Medication treatment is seen as controversial as the underlying condition leading to delirium is typically seen as the cause. One of the biggest differences between delirium and dementia is that dementia typically evolves progressively over months to years, while delirium typically has an acute onset. Alzheimer's dementia is the most prevalent cause of dementia. Dementia is associated with memory and executive functioning decline, a decreased quality of life, and systemic symptoms that limit activities of daily living, such as ability to feed oneself, bathe oneself, and meet other immediate daily needs. Dementia can also include changes in mood, affect, and psychotic symptoms. Any patient who presents with symptoms of memory loss, behavior change, or functional decline should be screened for dementia. However, early diagnosis can be difficult due to a reluctance on the patient's part of bringing up symptoms out of fear of losing their independence. One tool available for assessing for dementia is the Montreal Cognitive Assessment, MoCA. You can access this resource online, and the link is provided in the slides. Treatment for dementia is focused on increasing patient safety, functionality, and quality of life while reducing patient harm and caregiver stress. There is no cure for dementia and no way to reverse symptoms, but some treatments show slowing progression of the disease. These interventions include capacity evaluations, end-of-life planning, and medications. Both delirium and dementia are associated with higher rates of depression. However, depression can be more difficult to identify in older adults and presents differently than in younger adults. Depression in older adults often presents as somatic complaints of pain, unintentional weight or appetite changes, irritability, agitation, fatigue, headache, insomnia, hypersomnia, and weakness. Helpful tools for assessing for depression with older adults would be the Geriatric Depression Scale, GDS, and the Patient Health Questionnaire, PHQ-9. Interventions for depression typically include psychotropic medication and therapy. In considering whether your patient or client has delirium, dementia, or depression, it is important to remember the following. Delirium typically has an acute onset and most often resolves when the underlying physical condition is resolved. Dementia is most commonly associated with memory loss and cognitive decline, and depression is primarily associated with mood. These can all occur simultaneously or independently of one another, and care should be taken in ruling out one condition over another.